evening, Dr. Cabello.
Good morning, good evening, Pinky, Dr. Cabello. I'm so glad.
Yeah,
You
Agnes
can.
is my classmate. Dr. Mejia is my classmate.
Hi, Pinky.
Hi, Agnes.
Lagot tayo pag hindi tayo present. The dean is is in the forefront of our screens today. So that is very good. We're gonna give the audience a chance to log in. It's 8:27. Feb, thank you for the video of what PAASE is all about. It looks like we're going to have a large audience this evening, running at 79 is what I read right now, and it seems like more are coming.
We are also on Facebook Live, so you don't see.
May Facebook Live pa ba o 80 na? So we'll give them about three more minutes to get in, so that they will not miss a single moment of what Dr. Lachica will say. And of course, hopefully we'll have a very lively discussion and see if we can learn something. And this is a very dear subject to me, and it affects the whole gamut of healthcare. And I'm impressed. 86 people. Usually, when we had the research seminars, we average about 35, and the only topic that took on about 200 was on CRISPR, technology. Okay, so we are about to go on air here now in about a minute. So let me just take just about a 3-second break here, and then we will be starting.
I just want to greet my friend, a balik scientist, Annabelle Villalobos. Dr. Annabelle Villalobos is here. Hi, Annabelle.
Annabelle. Okay, I'll be on in about maybe hopefully 30, 15, 20 seconds. Oh, good. Oh, ano ba yun? Vicente Soto Hospital, DOH, Bataan. Very interesting. Okay, so I'll leave the admissions to Feb. Good morning to my beloved Philippines, and good evening to the from the land of the sea to shining sea, the United States. Today, we are going to be dealing with a topic that affects our care of patients. And before I introduce our speaker, Dr. Lachica, I would like to mention my co-host, Dr. Joel Peña, recently retired professor of the College of Medicine, otolaryngology, but I do not believe he's going to give up his scholarly pursuits because of medicine is his first endeavor. And apparently, Dr. La Peña, my co-host, will still be involved with perhaps as a senior consultant for the Ayala Health Group. So my co-host is Dr. Lachica. I will have a very short introduction to for Dr. Lachica. About 6 months ago, when Dean Mejia mentioned Dr. Lachica, I went into the literature, and one article caught my eye. This was an article regarding tertiary hospitals in Manila. It's sort of a local study. And they studied, Dr. Lachica was the senior author. They were able to gather 4,000 admissions to the tertiary hospitals of Manila, and 600 of those patients were readmitted. Were readmitted. And at the study, it showed that 42.9% were related to their experience in the hospital. So there is something going on with regards to the quality of care in our hospitals. So that's just one study among the many studies that Dr. Lachica has published. And now Dr. Lachica is actually the chair of the Patient Safety and Quality Assurance program at the Department of Medicine, the Philippine General Hospital. So without much ado, so we can really hear what we're here tonight and this morning. Ma'am, Dr. Lachica, you have the floor.
Thank you, sir. Good morning and good evening, everyone. I'm very delighted to be here. This is a huge platform for us. Thank you very much. I represent the program for healthcare quality and patient safety, as Sir Billy has said. So this is an important platform for us, for the program to be more or less known to our fellow safety advocates who are here today. Let me share my screen. And hopefully we can get on our way. All right. Can you see my screen?
Yes.
All right. Thank you, sir.
Yes. Can I make a request? Can you make it a slideshow?
Oh, is it? It's not going slideshow. Let me see. Sorry, I need to swap display. Sorry about that. But yes, I will do that. There. Is that okay?
Thank you. Yeah, perfect.
Wait, I think, sorry, 1 second just to make sure that I see everyone. I'll stop sharing first, very quickly. I'm sure people who are on Mac will identify with me when you're Mac challenged. Oh. Okay. Good. Oh, I'm sorry. Okay, I think we're all set. Thank you.
Absolutely.
All right. And thank you once again to the Philippine-American Academy of Science and Engineering. Thank you, Sir Billy, for the invitation, and I'm very humbly delighted that the platform here. No, so I'm going to talk about pursuing safe and quality healthcare in the Philippines. Admittedly, when I was trying to prepare for this presentation, there were a lot of things I wanted to share with everyone. Definitely the topic of safety and quality is a very, very broad topic. But I think I wanted to just focus on these items. So to just bring about, the urgency around unsafe care. And it's not just in the Philippines. I'm sure people will agree. It's a global problem. So we'll try to talk about that first, and then let's define patient safety and see what the challenges are. Why has it been so elusive for us to make sure that our patients get, zero harm? And how do we get there? How do we eliminate avoidable harm in healthcare? And I'll try to also present some of the findings of our study that we earlier did, and also provide a very sort of glimpse into what patient safety and QI now is in the Philippines. So I'll start with saying that this is a big problem. People come to us, our patients come to us in the hospital or in our primary care facilities, obviously wanting to get better, wanting to get care from healthcare providers. But there's that unfortunate consequence sometimes of being in the care, in the hospital or in the facilities wherein their patients are actually exposed to harm or are injured while seeking care with us. And it's been tremendous. There's been a tremendous attention to it, just because the burden is really big. In high-income countries, the studies would say it's about 1 out of 10 patients in the hospitals having an adverse event. Unfortunately, for us here in the Philippines, which belongs to the low-middle income countries, it's 1 out of 4. So it's a very enormous problem. And if you do look at the 1 out of 4 in low to middle income countries, that's actually going to equate to 2.6 million deaths and about 1.34 million adverse events occurring annually due to unsafe care in the hospitals. That statistic is not being, you can't see that from the top 10 killers, top 10 morbidity, mortality and morbidity census. It's a hidden statistic, but it's a very painful statistic, if I might say. And of course, these are the numbers. When you, and I'm sure all of you here, some of whom are in the local hospitals, in our healthcare facilities, some in academia. But if you're a frontline worker and something happens to your patients that are not really good, no, there's that psychological and emotional devastation that you see that happens to the patients themselves and to their families, of course. It's a very complicated reaction when your doctors, when your nurses, when your healthcare providers fail you in a way. And patients and families react very negatively, and their reactions are very much complicated because they put their trust in you so that you can actually make them better, but something else happens. And that emotional and psychological devastation is actually something that healthcare providers also feel, of course, and that's been very well documented. We are, as healthcare providers, can be what we call second victims. So we can be ourselves, traumatized, and we feel guilt, we feel shame, we feel incompetent, and that can obviously affect our performance and the care delivery that we give onwards from there. So the burden is really big, not just the numbers, but the complicated response to an adverse event while a patient is being cared for. And more unfortunate also problem is the economic burden of unsafe care. And these are all data that from outside of the Philippines. So it's a very big problem as well. So it's been said that about 15% of hospital expenditure can be attributed to wastage due to safety failure. So it can be when your systems fail to prevent infections, or when your patients fall. Of course, there are a lot of factors that cause patients to fall while they're with us, their medications, our environment, and all of those actually contribute to wastage. And in a country such as in the Philippines, where the resources can be very dire for some of the facilities, and of course for our patients, that can be catastrophic for them. In NHS in England, for example, their litigation costs can be went as high as 1.63 billion pounds. And in the US, 42 billion annually just from medication errors. You're not even putting in the expenditures for, let's say, unsafe surgery or from infections. These are just from medication errors. And that's why I think a few years back in the World Patient Safety Day theme was actually on medication safety. And while hospitals are, of course, catered to more complicated cases, and with healthcare more complicated, the chances of patients being harmed will be more. Primary care and ambulatory care are actually not exempt from safety issues. And in fact, if you have harms in primary care, actually represent, if you have additional tests and treatments that are unnecessary, they represent 2.5% of health expenditures. And poor care in primary care can actually result to 7 million more admissions. And that's in OECD countries. So that's the direct cost of actually providing unsafe care. But we do get to see, and it's an alarming amount, the indirect cost. So what happens when patients are harmed, and that there's a social cost to it, and it's valued at 1 trillion to 2 trillion a year. So people are obviously going to be unproductive. Some of them are going to be permanently disabled. So that really affects productivity. And it's been said in one study, eliminating harm in health can actually boost global economic growth by over 0.7% annually. So there's actually this is a big problem, but there's a real opportunity actually for better healthcare to actually impact on a bigger scale. Those are the data from other countries and some of the worldwide estimates. But how about in the Philippines? There are 3 question marks there in my slide. We don't actually know what the burden of medical harms and errors are in the Philippines, unfortunately. This might represent, our still growing awareness about safety. And that represents also maybe a challenge for us to actually contribute more and to be able to get to the data that will represent the Philippines. I did find, and one of the things I wanted to show you here was a study in PGH in 2017. This is by Dr. Paul Pasco, where they looked at chart entries, and they saw, and they just focused on medication errors, and they saw 97.8 prevalence of medication errors among the chart entries of our physicians. And as far as medication errors are concerned, the most common ones were errors in prescribing, and that's in decreasing order of frequency there. The next would be patient compliance. Patients aren't actually getting the medications as they were ordered. Medication administration by our nurses, and dispensing by our pharmacists. So, and you can see also the table there where there are frequencies of medication errors per department. Pediatrics had the most number in terms of percentage. And then we have medicine there, and OB and surgery. Errors in prescribing then were the most prevalent, because back in 2017, we still had paper charts. And if you can guess, the reason why errors in prescribing were the most common was because nobody can actually understand the doctor's handwriting. No? But now we have an electronic health record, what we call RADISH. Hopefully that problem has actually been solved in a way, because that's electronic records already. But I do, and I feel, however, that there are a new set of problems that we're encountering just with the EHR, and that can also contribute to medication errors. So back to my headline here, we need to establish how much of the medical harms and errors are happening here in the Philippines, because then we can have an idea, how while everyone here and everyone in the country are actually working towards safer care, how are we getting better? So we need to have a baseline. And let me start now by telling you about what patient safety is. And then the burden of unsafe care really is upon us. And I think there should be a realization that whenever we try to provide care for our patients, there really is a risk of harm. Nobody, or not one intervention is really 100% completely safe, right? And we need to acknowledge that. We need to be conscious of that, because that consciousness, that awareness will be the one that will make us be more aware, and also conscious of how we can mitigate the risk. And that's what patient safety is. It's the avoidance, prevention, and amelioration of adverse outcomes or injuries stemming from the process of healthcare. So how is the healthcare system, how is your healthcare provider actually putting patients at harm's way? Another way to look at patient safety is it's a discipline nowadays in the healthcare professions that apply safety science methods towards the goal of achieving a trustworthy system of reliable healthcare delivery. So this is now, I think I'll talk about how it came about, patient safety, but it's really started as a movement, and it's grown into a very important discipline, and it's been integrated in many of the healthcare professions education, but we do need to step up a little more. We've been talking about safety. Safety is freedom from accidental injury, if you see from the diagram. But we need to realize also that safety is just one part of the bigger goal, which is quality care. And of course, we always say first do no harm. That's the first and foremost. But we do have to also be conscientious about our interventions being effective. Are they efficient? Are we promoting wastage? We shouldn't make our healthcare interventions promote wastage. Are we timely? Are we promoting equitable health? And of course, patient experience. Are we responsive to what our patient needs? Are we able to listen to their expectations and actually heed to their expectations? So those are actually even broader domains of quality. But for the rest of the talk, I will be focusing more on safety. So how did patient safety thinking come about? After World War II, after the devastation, there was, of course, an emergence of more of the facilities, institutions investing in healthcare. And so people are getting more access to health care. And back then, whenever a patient, let's say, had a wrong transfusion or an incorrect surgery, it was headline. It's in the headlines. It's big news. There's a lot of discussion, and of course, sometimes even media attention to it. But it was regarded as something that's very rare, few and far between. And the response to it is that those healthcare workers should be more careful. And they need to be more careful to avoid these things from happening, because they're pointing at healthcare providers or healthcare workers or the hospitals being careless and maybe not really sticking to what the protocols say. And back then, if you actually had an adverse event, let's say from a medication, if you had an arrhythmia from digoxin, it's regarded as something that's inevitable, because that's part of the possible complications of the medication. And these harms, these injuries in healthcare are actually just the inevitable cost of a very high pressure environment such as healthcare delivery. And we just turn our backs and say, but most patients actually get better. Patients are actually being saved. But the other side of the picture where patients are actually harmed, these are few and far between. And mistakes, errors in healthcare happen because people make them, because people are just, some people might be more careful, some are less careful. But in the 1990s, many of those in the healthcare industry are starting to look at harms from healthcare as something more substantial than what we previously thought they were. These aren't, of course, headline makers, but these are creeping in their institutions and they're becoming more frequent. That high pressure, fast-paced environment, which is healthcare, is something that's not really very different from other high-risk industries like the aviation industry. And then you'll find in many literature now about patient safety that many of the principles, the concepts are actually linked or based from principles in aviation and making sure that people are actually safe while traveling in air. And terms such as medical error, adverse events, serious untoward incidents, your never events, no, those are shocking medical errors, and a near miss or a close call are actually being introduced, and people are becoming more aware that these are things that are happening, and these can be opportunities to learn. And mistakes happen. People are realizing that, but these can be avoided, and the impact of these mistakes can actually be reduced. So let's go now to why we make mistakes. And this was something that James Reason wrote about, no? Why humans make mistakes. And this was, of course, we're talking about healthcare, but this is in general, no? In general, why do we make mistakes? And not just in healthcare. Because we forget. Right? Because, and then this for my audience here, this can be a checklist for you. Do you get tired? Do you get overwhelmed? Can we be careless sometimes? Do we lack focus? Of course, as healthcare providers, it's not just our work that makes up our lives. We have our personal lives, we have our issues, and we can lack focus while at work. Sometimes we lack the training, or we're unaware of risks, right? And sometimes people just really don't care as much. So those are probably reasons why we make mistakes, but I'm sure you also are familiar with these, no? We are understaffed. And that's been a chronic problem. Our communication pathways fail. There are just too many confusing steps. No? When you try to do an intervention, when you try to do a procedure, the steps can be very confusing. Or in many facilities, I'm sure this is something that is being seen, no? Their equipment and their environment are actually unsafe or inadequate. And there are no protocols, no clear documentation of processes, and very, very common is we don't learn from our errors. So the first column actually takes on the person approach. The person-centered approach addresses the psychological causes of error, like inattention, forgetfulness, carelessness. And obviously, the countermeasures for such approach are typically directed at individuals rather than situations. So you provide disciplinary action, right? You give penalties. You have blaming, naming, and shaming, unfortunately. This is still a little prevalent, no? And aside from treating errors as moral issues, it isolates unsafe acts from their context, thus making it harder to uncover and eliminate recurrent error traps within the system. So you're putting the interventions towards a certain individual, but when the system is there, another individual comes in, and that individual is again prone to make the same mistake. It's a very attractive approach from a managerial perspective, but it's not really suited for healthcare, where it's very complicated. There are a lot of traps and there are a lot of system issues. Now, the other column is the system approach, which in contrast takes on a more holistic stance on the issues of failure. So it recognizes that many of the problems facing organizations are complex, ill-defined, and result from an interaction of a lot of factors. So it starts with the premise that we people, we humans, are actually fallible. We really make mistakes, and errors can be inevitable. But what can we do to make sure that these fallible and errors happening? What can we do to prevent them? So the important issue is not who made the error, but how and why did our defenses, our systems, our processes fail, and what factors help to create the conditions in which the errors occurred. So the system approach recognizes the resilience in the institution and promotes and recognizes the need for learning from previous errors. So what do we do? What do we do now? What do we know now about patient safety? That's most harm are avoidable actually. So this is the Swiss cheese model, where you see all of these slices of cheese, and when you try to look at an event where an error or an adverse event happened, you'll see that it's never just one person's fault. It's never just one thing. So when a patient, for example, which is very common in our hospital, where a patient falls, it's not just because, you know, the caregiver or bantay did not look at our patient. It's because maybe the floor is slippery or the way to the bathroom is too long for the patient, and there weren't safety mechanisms for patients to be more careful, or their caregivers to be more careful. We didn't do the full risk assessment. So those are things that actually contribute to when an adverse event happened. And these holes in the slices of cheese are actually weaknesses of your defense system, of your processes. And when they're aligned perfectly, unfortunately, accidents happen. So errors occur, as I said, because people are fallible. But you know, as providers, as many hospital administrators who are here, we need to understand is why do these occur? And errors occur because medicine is still treated as an art, not a science. No, in analyzing, you know, how errors occur, we should actually recognize the scientific nature of medicine and how it's very complicated. And we need to make sure that our healthcare workers are capable to learn from these mistakes, and the system can implement procedures to help prevent serious errors from happening again. We need to be more proactive, and by focusing on how people succeed and how we support our healthcare providers to be effective and efficient rather than on how they fail. And I like this line: human error should be seen as a consequence, not a cause of failure. And when we see this, when we realize this, then our response to adverse events is going to be very different. So what is the science of safety? You'll see it from on the right side, no? The system level factors that actually influence safe care and the culture of your unit. No, you start with the patient characteristics, how the family interacts with the patient and the staff, the team itself, the healthcare team providing care, the work environment. Do you have a lot of distractions, no? Or do you have unsafe equipment? Administrative, are the policies there? Are there supportive interventions for healthcare workers? Even regulatory, are there incentives to actually being, or disincentives for that matter, that will try to promote better or safer care? And every system is perfectly designed to achieve the end results. So when your hospital has a lot of healthcare associated infections, that's because your system is actually designed now to create such outcome. And once all team members understand that systems are designed to achieve the specific results, then we can actually be more prepared to provide system improvement. We need to recognize that safe design principles must be applied to technical work and teamwork. So what are the 3 principles of safe design? This is standardizing whenever possible. No, it's not an art anymore. It has to be a science. It has to be standardized. We should create independent checks, no? As a consequence of us having being prone to errors, and we should learn from defects. And lastly, let's actually promote teamwork. And teams that make intelligent decisions when they're provided with a diverse input. I've said this a lot of times in our rounds, for example. I'm not sure if that's the same with you, but doctors make rounds themselves, rounds, the pharmacists will have their own, the dietitians will have their own, and we're working in silos. When, an effective team actually integrates all of those, and we have the doctor, the nurse, the pharmacist, our ancillary partners, to make sure that the output from the entire team is actually a diverse one. And we know our weaknesses and strengths, and we can play on each other's and leverage on each other's strengths and weaknesses. So what are the challenges of to patient safety? Why is unsafe care still prevalent? Healthcare is becoming more complex. Of course, there are a lot of more treatments, more effective treatments, more complicated treatments, newer drugs, newer interventions. And we have to be able to adjust and be flexible and to anticipate the risks from these new interventions. It's a prevalent problem when errors are not disclosed in your facility, when people just, observe something but they don't speak up. Obviously, if these harms aren't communicated or are not reported, then we can't learn, we can't correct. As I said, healthcare workers usually work in isolation. I remember one adverse event from our institution where a drug, polymyxin, was actually given to a patient 10 times its dose. And the nurse that was who was preparing it was actually already sort of worried that is this the right dose, but she didn't feel like she wanted to tell someone about her hesitation about the dose, and she went ahead with the administration. So that's something that's not encouraged, of course. And I always say this, that when you work in isolation, you're actually an unsafe worker. Nobody's there to support you. Nobody's there to counter check you. And we need to build on that and to promote more effective communication. And I see this a lot, especially in our in the research that we've been doing, that there's a lack of data in safety, and there's a reluctance to measure performance. We don't really want to be measured. We don't want to be assessed or evaluated. But that evaluation and assessment can actually be helpful for us to be able to improve. Of course, I'm sure many of you will agree with me, the resources are really can be limited at times, and sometimes introduction of technology, while it means to improve care, it can also give issues. And patients are treated as mere recipients of our care. So they're just there so that we can actually give the care to them. We don't recognize that our patients themselves can actually be defenses to unsafe care. And so I wanted to show you, this is from the Institute of Healthcare Improvement, the framework for safe and reliable care. And this has been, a very validated and a very popular framework that has been taken on by a lot of organizations. How do we promote safe and reliable care? And at the center of it all is engagement of patients and families. Coming from what I said earlier, patients can actually be, patients are our partners in making sure also not just that the care is provided to them, but actually that the care we give them is safe. They can actually check us. Hopefully they feel free to also push back in some of the treatments, and that engagement is actually important. One thing that I wanted to put in the spotlight here is psychological safety. Psychological safety is actually, if your organization has it, people are actually they don't have any hesitations about speaking up when somebody commits a mistake or when they think that the system will fail. There's no threat of humiliation or demotion. And accountability. People have to know that they're accountable for their actions, and that will make them more cautious. As I said, teamwork and communication are key. And negotiation, what this means basically is knowing what matters to the patients, knowing what matters to providers. And there are definitely going to be some differences, but we need to have that negotiation skills to make sure that all of our stakeholders are actually at play. And those 4 cogs there actually build the culture for which safe and reliable care will come about. On the lower side is the learning system. You know, when you report errors, when there's transparency, everyone knows where they're good at or where they're not good at. You know? Reliability, for example, in your organization, what are 5 things that you consistently do? What are 5 things that you actually adhere to? And improvement and measurement. So how do we know how many infections are here? How many times these protocols are not being adhered to? And learning from, you know, from errors and from when adverse things happens. And that blue cog, those blue cogs there is actually the learning system that again promotes safe care. And lastly, I'll talk about this some more later, is leadership. We always say this, people really say this, that safety is actually a leadership business. It's top down. And when your leadership is engaged, when your leadership focuses on safety and quality, then it really makes it easier for the entire institution to be on board with it. This framework, the goal is really, you know, is your institution able to self-reflect? So when you're doing your duties or when an adverse event happens, can you actually look into yourselves, look into your process and see where the gaps are, you know? And after you've self-reflected, is your system, is your facilities, your organization able to improve? So is it improvement capable? Can you look at those defects and can you actually try to improve from those defects? So those are the goals. Are you self-reflecting as an institution and are you improvement capable? And this framework is, as I said, has been used by many systems. People will ask, is there something that's more important here, you know, or can we just pick out parts of this framework? Actually, no, this framework is like the human body. No? So it's a complete picture. Every cog is important, no? Much like all of the organs in our body will be important. And we're talking about culture. I want you to reflect now. These are the different maturities of safety culture. Reflect on your unit or your hospital or your institution. Are you a system where it's still unmindful? You know, who cares about safety as long as we're not caught? Or are you reactive? When something happens, you know, we do a lot of things to react to the accident or the injury. But when you're in a systematic culture maturity, that means you're actually seeing patterns. You're already seeing where this has been happening and the system failures are here. So we have to put interventions in place to manage the hazards. And as you see here, the tipping point is psychological safety, because if people are free to say and people are free to report what they're seeing, then you can actually look at the system now and try to change it. But a step beyond that is being proactive, where you're already anticipating and preventing problems before they even occur. And that's going to happen in an institution where people are really comfortable speaking up. And lastly, you know, this is the generative maturity model, where people are going into work, they're more fun. The work is more fun because they're really anticipating and they're confident and they know that they're going to be supported, and their people are actually working together more effectively. So where are you in this spectrum? And hopefully you get to the next level of maturity as you work with your institutions. And as I said, leadership is really a big deal. That also represents the leadership here in the slide represents, no, if you're unmindful, maybe you don't really see your senior leadership, no, where are they? We don't really see them in my daily duties. But when they're reactive, you know, maybe you see your leaders just because there's something happened, a patient complaint, you know, or a sentinel event happened. But in a systematic safety culture, maybe there are more interactions between the senior leaders and the frontline staff. And if there's systematic engagement, there's really a coordinated effort between management, your leadership, and your frontline staff, then that's when you're thinking ahead, when you're anticipating problems. And if it's in the generative safety culture model, then you're flow of information is really systematic. It's very, it's very much integrated, and it's the norm already. So where are you also in the senior leadership model of culture? And I hope you can really, again, progress to more mature ones. So I tried to, give some glimpse about what we know about patient safety, safety design, the framework for safe and reliable care. But going back to where we are, the UHC law actually creates this urgency already, apart from all of those that I mentioned. The UHC law asks PhilHealth to develop differential payment schemes, as you all would know, that give due consideration to quality, efficiency, and safety. So we have to work now. There's really it's really on us, to create better quality and safety. Before it was fee for service. For some systems, it's still fee for service, and we're still paid for each service that we provide. But now with the UHC law and with what PhilHealth is doing is we're going to global payments and capitation and prospective payments. So of course, if you're given a certain payment for a certain time to give your services, and you do encounter a lot of safety issues, you have a lot of healthcare associated infections, or you have adverse events, then definitely the cost will be higher. And your institutions, your facilities are going to be left with less. And so to avoid that, then systems have to be changed. And we move towards more value-based care, where we aim to change the system where we deliver care that helps patients get better while keeping our costs down. And so very quickly, I wanted to show you what I think what people generally regard as more prevalent, is quality assurance. We've heard it a lot of times, but there's another approach, which is QI, or quality improvement, and they aim to enhance quality of care, but they do so in different ways. So, for example, for quality assurance, it's to ensure that your healthcare services meet predetermined standards and guidelines. So it's really based on monitoring and documenting whether you're in compliance with the standards. But with quality improvement, that's continuously improving or enhancing the quality of care and outcomes. So it's more proactive. And for QA, it's really more compliance driven. But in QI, it focuses on analyzing your processes, identifying inefficiencies, and system level changes to make things safer. Very, very much the focus for QI is the system. For QA, it might be a focus really on the incidents. And QA usually takes on a retrospective approach. You have an incident, or you have probably failure. So you measure or you assess because you didn't go and you failed to get to an established criteria or benchmark. But with QI, it's actually iterative. And while you're changing your systems, that's going to be data driven. You analyze your processes and you use improvement methodologies to improve care. And the motivation for QA is to be accredited because you have to meet a certain standard or maybe reimbursement. But the motivation for QI is, excellence and really improving outcomes. And we never stop. That's something that's it's continuous, and we never stop making sure that our care is better. So QA is actually narrower in scope. If you think about it, QA is much more broad. So both approaches are essential, definitely, but we need to take them both together. So you can have a more comprehensive quality management system in healthcare. So there will be people that are going to take on the QA, and there are also people who will take on the QI. So those are what I wanted to share as far as patient safety, quality, QI is concerned. But let me try to share now more on the local context and what our work has been for safety. This is in 2008, DOH already had an administrative order on patient safety. And it says to ensure that patient safety is institutionalized as a fundamental principle of healthcare delivery system in improving outcomes. So with that, DOH-AO facilities were asked to really build on patient safety programs, And they called for an efficient and effective monitoring system that will link all patient safety initiatives. However, when we looked at what we have done or what the nation has done after the AO, of course, we saw a lot of improvements. We saw a lot of initiatives towards patient safety. But explicit targets and institutional performance on these are actually missing. So there was a need to establish the nature and extent of harm attributed to medical care, as I said earlier. So this made us take on our project, which was under the AHEAD program of the UH. No? Our project was called Assessment of Performance Measures and Indicators of Patient Safety. And we wanted to see what's being done now and before, in government and private hospitals. How are you assessing your performance, and how are you evaluating whether you've achieved patient safety? So we evaluated the available measures, and later on we built consensus about with the stakeholders so that we can actually have a set of minimum indicators to say, this hospital might be needing more improvement compared to this hospital. And we envision that those performance indicators can actually be linked to incentives and nationally implemented targets. So I'd like to, so we took on actually a mixed methods approach. We had a hospital patient safety indicator survey. So we looked at what the current measures are. We triangulated it with documents review, how are hospitals actually measuring, for example, falls or the processes that prevent falls. And then we also had the qualitative methodology where we interviewed key informants in the hospital, your administrators, your patient safety officers. We also had focus group discussions with frontline workers to triangulate what we saw from the documents review. And this is what we found, some of the things we found. So this is our article, our first article on the description of core performance measures on patient safety. So when we looked at the literature on patient safety measures and indicators, we looked at and we saw that there was core indicators. These are items that cover overarching processes and concepts in safety, the bigger picture items. So what are the resources given for patient safety? Is risk being assessed and managed? Are there reporting and learning systems? And is there patient and family engagement? These are what we saw. So in our study, we had 41 hospitals, 12 level 2, composed of 6 LGU, 5 DOH, and a private hospital. And we had 29 level 3 hospitals that included 2 LGU, 24 DOH, and 2 private and the National University Hospital. So that what did we see? You will see here that reporting of events, near misses, and other patient safety related data are widely varied among hospitals. It's less consistently done among level 2 and LGU hospitals. Okay. When we triangulated this, we had our conversations there. We also noted that learning from and utilizing these data for quality improvement are actually not fully established. So first, the data is lacking, the monitoring is lacking. And when they do have the monitoring data, institutions aren't really using the data systematically to improve care. Leadership and governance should recognize that this data-driven approach is important. We also, from our findings, we also noted that when you say patient involvement or patient-centeredness, that only equated, when they said yes to this, that actually equated to just giving out patient satisfaction surveys or feedback forms, the boxes where patients are asked to just leave their feedback forms. But that's not really patient engagement, right? So the understanding of what patient-centeredness is, what patient engagement is also lacking. What else did we see? Only about 32 and 36% of hospitals monitor what we call never events and near misses. So when we say never events, these are shocking medical errors that should never occur. These are actually 29 events. Examples are surgery on a wrong body part or a maternal death in the facility. Those are 29 never events, and only about 32% of hospitals are reporting it. And a near miss, On the other hand, is an error or an unplanned event which has the potential to cause harm, but because of chance or because it was intercepted, then the harm didn't occur. And these near misses, we need to learn from them, even if they don't actually resulted in harm. And for our institutions, only about 36% actually monitor these near misses. And as far as we use the AHRQ, patient safety indicators. These are the pressure ulcer rate, death rates, etc. These are all validated measures for patient safety. Amongst all of these, only one indicator, the transfusion reaction count, is actually monitored by at least half of the hospitals observed. So most of them are actually not being reported or measured by the hospitals. And what we saw also is that many hospitals rely on incident reporting. So incident reporting sometimes can tend to be more personal rather than systems. And there's usually a punitive approach when incident reports are given. And finally, what we saw also, that there's a very prevalent hierarchical culture in hospitals, which limit personnel from speaking up to their seniors or to their supervisors in addressing patient safety issues. And we also, actually in the study, we looked at the 6 international patient safety goals. This was made by the Joint Commission International, identifying patients correctly, improving effective communication, improving the safety of high alert medications, ensuring safe surgery, reducing infection in the hospital, and reducing falls. And among all of these IPSGs, when you looked at the hospitals, the 41 hospitals, infection control was the most, the one that had the most attention. I think it probably stands for the fact that actually infection control standards were actually in place even before the patient safety standards were in place. So that's the more common one that we saw, but the ones that were least looked at by hospitals is false prevention and effective communication. But I'm sure you all agree with me that those are equally important in assuring patient safety. So what we also saw was that policies and procedures were there. Actually, hospitals had policies and procedures, but reviewing these procedures regularly and updating them from the latest guidelines are less consistently done by the hospitals. And lastly, even while there are policies and procedures, when the patient load becomes too high, when it becomes too burdensome, the conduct of care delivery becomes less consistent with what the policy or the protocol said. So that's what we saw from our HEAD study. And after the study, what we did was to also convene a lot of our stakeholders from the DOH, from PhilHealth, from the Philippine Hospital Association, actually, from patients, and we tried to agree on a minimum set of standards for patient safety. And that engagement and stakeholder process is actually what we had the output for patient safety indicators. We had the list, and that was something that we recommended to the DOH, and it's now the basis for the patient safety indicators in the DOH Data Collect Hub. The Data Collect Hub for patient safety, I think, started last year, and we are trying to work with DOH to analyze the data. As far as I know, I think there's already one set of data with amongst 1,600 hospitals, but again, we envision this to be a dashboard. Where are we now? A visual representation of patient safety in the Philippines, and we're able to actually pick out which institutions will probably need more help, maybe need resources from DOH or from programs like us, and can be used as a benchmark for later evaluation. Last few things, this is the Global Patient Safety Action Plan from the WHO. It provides a framework for action through 7 strategic objectives, the one that you see, the triangles you see below. So it's policies to eliminate avoidable harm, high reliability systems, safety of clinical processes, again, patient and family engagement, our health workers' safety and education, information and research, and synergy. So, but there are also 7 guiding principles, the pillars, patients as family and families as partners, collaboration, learning from data, safety culture, policies and actions, etc. So it tells us, actually, this action plan tells us, no, that patient safety is everybody's business. So it's governments, healthcare facilities, stakeholders, and even WHO. So we need everyone's active participation, including also patients themselves, and non-government and professional organizations. So that's the overall picture. Globally, on the national front, the National Patient Safety Program Strategic Plan from 2023. Again, this also includes, of course, patients and their families, but these are the implementation strategies that DOH and the Technical Working Group on Patient Safety came up with. Still, the advocacy for culture of safety, implementing standards, learning and development opportunities, responsive program implementation, linkages, and monitoring evaluation. So we actually look at these frameworks as our guiding anchors, of course, when we take on patient safety. And those are actually our basis, for what we want to achieve as a program for healthcare quality and patient safety. Our vision is to provide safer healthcare for the Filipino, and we are a program with high level expertise. We're composed of a multi-professional team. So we have, our team is actually composed of doctors, nurses and pharmacists, and we do have my mentor here, Dr. Agnes Mejia, former dean, who's also our advisor now for the program, and our consultant is Dr. Vic Malabonga, who's been helping us shape our program and think about ways on how to be more effective in the program. Our framework is triangle. We really center with the patient. We work with healthcare providers in the healthcare environment through research, education, and innovations. And these are our goals. We did have short-term goals about just increasing the research on patient safety. And medium term, we want to educate, and that's why we've taken on a lot of activities to improve awareness and understanding of patient safety and quality improvement. That included, the AHEAD project, where we try to establish the healthcare quality and patient safety indicators. And on the longer term, we're trying to build on patients working for patient safety. And these are our priority projects for the next 5 years. I'll take you through them quickly. So firstly is institutionalizing and strengthening patient safety and QI in the medical curriculum, because admittedly, the current medical curricula is not really that, there's no explicit patient safety and QI. But we do have some offerings already in UP and PGH. But we're trying to take on a training needs assessment. Where are the training needs for patient safety and QI? And that can be hopefully something that we can share with everyone once we do get them. And we're trying to develop and integrate patient safety in our simulation modules in the UP College of Medicine. We are creating activities to promote interprofessional collaboration. As I said earlier, multi-professional, diverse input is necessary for effective teamwork. So we've partnered from different colleges, and this is something that hopefully our audience will try to do in their facilities or in their academic institutions, where we start them young. Even as early as undergraduate, we make our students be able to communicate, be able to collaborate with their colleagues from the other healthcare professions. So here you have students doing rounds, and it's not just all medical students. These are medical, pharmacy, and nursing students who are communicating, talking about the patients, and talking with the patients about how their multi-professional plan will happen. We want to conduct more patient safety and QI research in PGH and in our select network hospitals. We're actually the lead convener for safety in the UP-PGH Harmonized Agenda. We're also looking at these priority topics for research and our offshoot topics from the AHEAD. Our AHEAD project was really based on level 2 and level 3 hospitals, but as I said, primary care is a big concern. So we'd like to also look at patient safety performance measures and indicators in primary care, and to promote more tools for patient-centeredness and patient engagement. Last few slides, conducting training and enrichment. So we want to build capacity in patient safety, and we've done that through in-house in the UP Manila, but we also reached out to and we conducted basic, we're also designing an advanced course on patient safety and QI. So I'm not sure if some of our audience were able to participate in these past patient safety congresses. The last one that we had was an online one, the Synergized Approach to Patient and Healthcare Worker Safety. We had our Patient Safety and Healthcare Quality Forum last year. But this is an invitation to everyone here to register for the 4th Patient Safety Congress, which will happen on September 12 to 13. This is already face-to-face, and we'd like to see you there in Crown Plaza. This is the DOH Academy e-learning platform where our basic course on patient safety and QI is housed. This is free, online, and asynchronous. So you can actually move in and out of the modules so you can learn more about patient safety and QI. It includes concepts of safe design, impact of error, safety culture, patient safety issues like healthcare-associated infections, and effective teamwork. We've tried to maintain our ahead network of hospitals. So we've been collaborating with them with training modules, and we'll try to also implement patient safety dashboard with them. And lastly, we have also we're partnering with the Philippine Alliance of Patient Organizations to build more awareness on patient safety. We need to create the demand for safety among our patients, and we can really help them to be with us in this journey. So moving forward, maybe when you look back into your organization, your unit, your institution, is your institution self-reflecting? Are you able to offer a culture where everyone can actually speak up? And are you improvement capable? Can you actually assess your performance, and can you try on interventions and measure whether improvements are happening? And leadership is key. Leadership creates the culture. What is acceptable, what is not, what should be our goal as an institution. And leadership will tell us that quality is a shared responsibility. So it's not just from among the few. And we need to, shouldn't just produce excellent individuals, but we need to work effectively in dynamic and interprofessional teams who appreciate the system's approach and can effectively engage patients and families. So with that, I'd like to thank you. This is our team from the program. We're not complete there, but very happy to be here, and would like to take on any questions that you may have. Thank you very much.
Thank you.
Thank you, Dr. Lachica. Before I call on Dr. La Peña to introduce our first reactor, I am so impressed with, first of all, the lecture, and also the attendance of healthcare community in the Philippines. I invited the department heads of the Department of Health under the advice of Dr. Malabonga, and I invited all the way from Batanes down to Zulo. So here they are, and they are in attendance. I did not expect this attendance and this interest in making sure that we may be the brightest and the greatest in medicine, but if we operate on the wrong leg, on the wrong side of the brain, we are in trouble. So Dr. La Peña, sir, your turn.
Thank you. Thank you, Dr. Lachica. Indeed, poor is the pupil who does not surpass his master. And with apologies to Da Vinci, I would like to paraphrase that to poor is the student who does not surpass her teacher or her mentor. In this case, it is my privilege to introduce the mentor, who I'm sure is also very proud of you, Diana. I would like to claim that I was your teacher also, but I was in no way as big an influence on you as the reactor was and still is. Professor Emeritus Agnes Mejia graduated from the University of the Philippines College of Medicine, and finished her internal medicine residency at the Philippine General Hospital. She completed a fellowship in nephrology under Dr. Victor Polak and a 3-year fellowship in hypertension under Dr. Stevo Julius, who I think influenced her in terms of learning humility. Dr. Mejia, Professor Mejia, joined the UPCM Department of Medicine, Division of Nephrology in 1990, capped by her deanship, and I must add, this was my favorite dean to serve under, from 2012 to 2018. And it is noteworthy that her inaugural address 12 years ago, and I quote, said that patient safety will be the college's main research agenda. So this was what she said 12 years ago. Moving forward, she was the Gloria Aragon Most Illustrious Faculty Awardee in 2017 and the PCP Distinguished Internist in 2021, the International Society of Nephrology Pioneer Awardee for Oceania and Southeast Asia in 2023, and the highlight of her, or one of the highlights of her academic leadership, was receiving the ASEAN University Network Quality Assurance Certification for the quality of its basic medical education program in 2018, which the first and only medical school in the Philippines to receive this distinction. Allow me to show what I believe, Feb, next slide please, is a tremendous, amazing accomplishment of hers. Ladies and gentlemen, if you haven't seen a textbook that was developed properly, evidence-based, done the right way, you should get a copy of this book. And I'm very, very proud to say that this was mainly the work of our reactor. I would also like to greet you, Agnes. Happy birthday tomorrow. And I now turn the floor over to you.
Oh my. Yeah, thank you, Joey. You got me there. And Billy, Vic, and Dayan. I recruited Dayan for this project, and I am fully indebted to Dayan and Lynn Panganiban, who spearheaded this program. But my reaction will just be very brief, and I just want to relay the breakthrough, how we came to this point. Since 2012, when I announced this as my flagship program, the first breakthrough was when we got a 70 million grant from PCHRD to do studies on basic and clinical sciences. Basic is safety of herbal medicines and clinical research for false medication errors, etc. And this was supervised by Arman Crisostomo and Ruchicaro. In the interim, probably many didn't know, Arman and I have visited the DOH under Dr. Ona, and then Yusek Herbosa, and later Secretary Obial, because we wanted financial support. Arman and I and Brian Lim also drafted a law for patient safety, and we presented this to the Chief of Staff of a senator, but we were sidetracked by the Mamancipano ba yun? Tragedy, and so this was put aside, but we still have that draft. And the second breakthrough was when we had this ahead. This is when Dayan and Lynn Panganiban were recruited, and this was in 2015, I think. And I see this ahead project as the seed to secure more grants, to support more plans, and to be a real academic hub. And the third breakthrough is when the Board of Regents approved this in 2017, the Program for Healthcare Quality and Patient Safety. But I think the last breakthrough and the beginning of more breakthroughs was in 2024, when this program was given a personality, when finally Tamondong-Lachica was appointed as head of this program. I cannot imagine having a program without a head who's officially appointed by the institution, because she needs a personality to be able to collaborate with the other colleges, both in UP and outside. So our goal for everyone to know is actually to secure more grants and financial support. We have the list of activities that need support. We need the law, because from the law we can get the financial assistance. And I don't see why a law cannot be approved, because everyone at some point in time will be patients, and patient safety is actually the prime obligation of anyone connected with health, or even those not connected with health, like the families and all. And of course, the dream is to be a center. But I don't want a center that's empty. You know, meron dyan center pero wala naman nangyayari. So we are taking our time, maybe in a year or two, when we have gathered our researches and we have built up our capacities and training, then we would have the guts and the grit and lakas ng loob to really apply for a center. I know how it is applied, but I want to be ready for it. I want a good staff. And as I said, I'm indebted to Dayan and Lynn, but I have a small group and I like working with small groups. And for those you have seen there's Jen Pagio from nursing, Carl Su from anesthesia, Connie Season, who finished her master's in Johns Hopkins on patient safety, Dion Guiran, who is our internist, Francis, Professor Yoli, and Charles from pharmacy, and a few more. So it's a small group. We meet regularly. So I made it clear when I presented this to the President's Advisory Committee that UPCN will be in charge of this patient safety program, not NIH. And we want to be an academic hub. We will teach them, we will mentor them, but we cannot be implementing them. And this is where we had tapped Sentinel hospitals who would be implementing this program. And we can spread all over the country, but we in UP will be an academic hub. And PGH will be a good place to implement it. So we're getting connected with that. And there are several very interested hospitals, and I'm sure we have identified about 5 whom we can call as Sentinel hospitals who can really promote patient safety. Then we can spread as we go along. Hopefully when the center is there and when these people, I specifically chose young people. And these young people, except for Lynn Panliban, who has just retired, these are very young people who I think will grow with the program. And they have not shown any reluctance at all in continuing what we have started in 2012. Thank you.
All right. I have the pleasure and honor of introducing the next reactor. I may be brief, but Dr. Malabonga, and you can read what is in the screen. So, what does it say? Currently, CEO of SR Consulting. Ano ba yan? Yung pala, ito pala ang tinatanong kung how do you implement patient safety and quality care. So, with regards to the first slide of Dr. Lachica, the implementation of patient safety and quality care is elusive. So, Dr. Malabonga, of course, is a graduate of the College of Medicine of the University of the Philippines. I will mention some personal things that I know of Dr. Malabonga. He went to the Philippines with his own funds to go and interact with the Philippine General Hospital. We had him as a faculty visitor there, and he went 2-3 times, spending his own money. So there it is. It's a personal commitment on how patient safety will go. So, sir, without much ado, would you kindly give us your reaction to the exposition of Dr. Lachica?
Thank you for the nice introduction, Billy. I'm so honored to be participate in this fireside chat. Hi, Joey. Thank you again for being a moderator, and our Dean, Mejia, whom I've been working with in patient safety since at least 2015. And Diane, that was a wonderful presentation. You touched on a variety of topics, and I know you couldn't go as in-depth as you wanted to, but that was pretty deep. And for the audience, I'm sure you hopefully had some appreciation of the challenges and the opportunities that are presented in the current hospital environment in the Philippines for patient safety. So my reaction is try to provide some perspective from the standpoint of the actual establishment and development of the patient safety program, because you got patient safety, you got quality, but for the audience, what does this mean? Because practically speaking, that's supposed to be the next step. And so for the audience, I just want to let you know, there are two major perspectives in the establishment and development of a program. One is the what, and number two is the how. The what is the knowledge base. And there's a lot of that in the literature, and you have lots of people who are subject matter experts. The how is the more difficult component, because the question becomes, how do we get from here to there? And I think Diane alluded to that early in her talk. But the more critical question is, how does the program look like once it's fully running? Dr. Lachica described terms of that involve quality and patient safety and components and parts and different systems. But in your own environment, in your own hospital, in your own institution, how do you know how it looks like? Understanding that every facility is unique in its own way. So starting out for the audience, as you go back home and discuss with your leadership or your members, you'll be faced with, like, somebody gave you a 3,000-piece jigsaw puzzle, but didn't tell you how the final picture would look like. So you've got these 3,000 little pieces, you know how to put it together, but you don't know what you're trying to build. And that is the reason why this how, you've got the what, which can be readily provided, but the how becomes the major stumbling block in the development of a quality and patient safety program. And when you look at the literature of the experience of the rollout in the United States of quality and safety programs, the consensus, there are three important elements, and Dr. Lachica mentioned this. Number one is leadership commitment. Number two is the culture of safety. And number three is the widespread application of performance improvement tools and interventions. But I'm asking the audience, how many of you know what leadership commitment looks like? And how many of you understand what the culture of safety looks like? How do you feel it? How do you know it? How do you see it? So you start dealing with abstractions and nebulous pictures, and you lose hope, right? Because you can't touch it, you can't see it, you can't feel it. And that is where the role of somebody like coming from a central coordinating center, like what Dr. Mejia was saying, to be the driver of the development and the dissemination of the programs across the country. But basically, the development of patient safety and quality programs in your individual facilities will have to involve direct involvement with or direct association with a person or group of persons who actually know and have seen and have felt what leadership commitment, the culture of safety are, and have actually applied and used the performance improvement tools and intervention. You can't do it alone, because you don't know what that final picture looks like of that jigsaw puzzle that's sitting in your table. And when you look at the articles that were published, as I was mentioning, these are critical success factors, there is an underlying assumption for all three. And that is that an infrastructure is present. An infrastructure to establish and maintain culture of safety, and an infrastructure to oversee the application of performance improvement tools and interventions. But I ask the audience again, do you know what that infrastructure looks like? Do you know how it's put together? Do you know how it relates to the patient safety officer and the quality management office? Do you know how it relates to the executive leadership? These are important questions as you move forward. And this is where the consultant's role comes in. Final words, all this movement towards quality and patient safety, it's difficult because in reality, it requires organizational transformation. Okay, it's not just all the stuff Dr. Lachica talked to you about. The big picture is it requires organizational transformation, because you cannot think the same way and you cannot do things the same way, expecting different results. Thank you for the opportunity.
Okay, wow. What a morning, what an evening. We're going to have a question and answer period now, and I've asked you to type your questions in the chat box or raise your hand in the reaction box. Okay, we have two questions already. I was going to start with a question first, but Just Santos of PAASE is asking, question number 1, errors can also be attributed to patients not fully disclosing medications they are taking, which in combination may cause dire results. Was this and other patient undisclosed medical information explicitly considered in your findings? I
Yes,
think
sir.
he's referring to the study that was published, yeah?
Yes, sir. The one po about medication errors po siguro, no. Yes, I think that there wasn't really an explicit look into what factors made the patient not comply or adhere to the ordered medication. But yes, no, there's that factor where patients don't really disclose what their apprehensions are about their medication. But that's something that we need to work on with them. That as I was saying, patient engagement, being actually involved in the decision making, that might help make them be more adherent, and maybe can push back on certain medications, especially if they think that those are really helpful for them. So, but just to answer the question po, hindi kasama yung factors kasi, but definitely that might have played a role on why we saw those numbers there.
And I think that's also quite pertinent in the sense that many patients are taking off-label supplements and other things that they get from social media and friends, and these are bioactive compounds. So we may actually need to do some research in that area. Question number 2, Vic. Yeah.
Yeah, that actually is a very important the situation in that question is really important in patient management and patient safety practice that can mitigate the effects of off-side medications. It's called medication reconciliation. And it's a practice that you apply both in the clinic every time you see the patient, and when the patient gets admitted into the hospital, and when the patient gets transferred from one unit to another, and then when the patient gets discharged. But the onus is on the physician or the nurse to do the query. Basically, we need to directly ask the patient, as you're going through the prescribed medications, which one of these are you taking and how? Then after that, are there any medications that are not in this list that you are taking from another doctor, over the counter? And then if they say nothing, how about this vitamin or that vitamin or this herb or this?
Yep.
So because patients may not be willing to volunteer the information, or they don't think that excuse me, what they're taking it has drug-like effects. Only we know that, and so that is a form of proactive management. Just wanted to share that.
And that's a very fertile area for more research and involvement, I think. It's also very important. If I can go to the next question, with the advent of AI, which, for example, can transcribe or computerize doctor's notes na mahirap basahin. Do you, okay, guilty, male. Do you foresee AI technologies helping to improve patient safety? Diana?
Yes, sir. I think that the short answer there is yes. I think any technology can actually help to improve patient safety. For AI, we've been seeing some promise with regards to patient safety. I think yung computerizing and transcribing doctor's notes, that's maybe yung mas more EHR yung ano doon, ano. But having an EHR definitely can help with safety because you're looking at like a consistent note that everyone from the team can actually look into and see, and can promote more, checkbacks and independent checks. For example, in PGH, our electronic health records help us to monitor what our patients are experiencing. For example, when we did try to implement order sets, Dr. Malabonga gave us that idea to implement order sets, for example, in heart failure, where patients get a minimum set of interventions for heart failure. We're able to see already what outcomes are improving, what processes are improving. Are our patients getting to the echoes on time, or are they getting unnecessary, tests? So EHRs help in that sense because it can make data more available, which before would have been just possible with research that will take a long time, right? But AI per se, that can also help, and I think it has been done already where with data, numerous data from hospitals, insurance claims, you can actually see what types of patients respond to different interventions and the differences. And we can anticipate. I think that's the main, that might be the one of the things that AI can help with anticipating problems and anticipating which patients will and will not fare well with certain interventions. But it's a very promising field. We need to take it seriously but cautiously. And just a very quick promotion, because in the 4th Patient Safety Congress, we will actually tackle AI and patient safety in one of the plenaries. So if you're really interested and we'd like to know more from our experts about that, then please do attend the 4th Patient Safety Congress.
Diana, before I read the next question and call Vic, could you put in the chat how people can contact you, or
Yes, sir.
I'm sure people are interested in maybe learning more, because you packed so much into such a short period of time. And we have people representing different health institutions and hospitals all over the country in attendance today. Can you please type how they can get in touch with your group, maybe for a workshop or future talks? Okay. And Vic, can I read Juice's? No. Okay. We'll have Vic first. Yeah.
Oh, yeah. So regarding the question about medical records and medication errors, the literature is clear that the widespread use of physician order entry reduces the confusion with regards to the drug name, the dose, the frequency, and the mode of administration. Because, well, once it's printed out in the computer screen, it's clear, right? Where AI will have a role is in the modifications required of dose, route, and frequency in specific clinical settings, such as underlying conditions, comorbidities, and drug-drug interactions, which the physician may not be aware of. So an inattentive physician, patient with say gram-negative pneumonia with sepsis, will order Zosyn 1 gram Q6 IV. But the guy is now a creatinine of 8 or maybe 10, and the physician's not aware for whatever reason. And AI can come in and recommend a dose modification or a frequency modification. And then there could be a drug-drug interaction that, again, the ordering physician's unaware, and the AI can alert that physician as to, or the ordering physician, as to the presence of the potential for that interaction. Just wanted to throw that in.
Yeah. Thank you. Thank you, Vic. Our president, Gladys Completo, has her hand raised.
Hi. Good morning, everyone. So
Good morning.
I'd like to applaud Dr. Lachica for giving a very good presentation, and of course the team, Doc Billy, Doc Joey, and Dean Mejia and Vic for giving a very good fireside chat on patient safety. And also, I just learned that this started in 2012, and now your program is now doing a lot of activities. So in your presentation, Dr. Lachica, you mentioned that I'm actually, because I'm an educator at the same time and also a scientist, so I was very happy to know that there are course offerings now that's being done in UP Manila. And I noticed there's a lot of SUCs who are planning to have their own medical, to have their own medical programs. So are you planning to involve them in implementing these courses so that, these medical students, nursing students, and all pharmacy students will learn about will learn to collaborate and really come up with, the team and how a team works with the aim of the having safety, healthcare quality and patient safety. So that's my first question. And maybe I just visit, are you also considering the safety of the doctors? We're very concerned about the patient safety. How about the doctors? Are we also considering the after effect? That's it. Those are my 2 questions. Thank you.
Thank you, ma'am. Siguro I'll answer the second question first. No, as far as protecting the healthcare worker. I mean, this is paramount, of course. We need to protect ourselves. We need to be safe and healthy, to be able to provide care. And that has been one of the topics actually for the World Patient Safety Day a few days back also was safety of healthcare workers, especially in the context of the pandemic and all that. But apart from physical harm, we're prone to getting infections. There's also as I said earlier, the emotional harm that can happen. Of course, you have burnout, you have that's really that can take a toll to our healthcare workers. And but when patients actually get harmed, it's something that we sometimes very much go down the drain on and really just blame ourselves. But as I said, it's not really the just the person, right? It's something that the system might help. I remember there was a trainee of mine in residency, for some reason, actually multiple reasons, the order for potassium supplementation was given, but the patient wasn't really hypokalemic, hindi naman talaga mababa yung potassium. And he was distraught. He was very much depressed, and for a time didn't really want to continue on with training. And I fear that that's something that's very prevalent, no, especially if it's in a training program context, no, that we just want this person not to be in the program, or make them not be part of the program anymore. But when we looked at what happened, it's really because the system there wasn't really checkbacks, there wasn't really any feedback. That person didn't have someone looking over. I think the nurse had a suspicion that it might not have been useful for that patient, but they didn't speak up. So I mean, those are if you're really in a team, then that could have been prevented. But it doesn't make us take out the opportunity for this trainee to continue with training. And what we did for this person was to mentor, to coach, to support, especially with thoughts about guilt and shame. And that's something I'm sure all of us here have made mistakes, no? Some of them have harmed the patient, most of them would not have harmed the patient, fortunately. But mistakes are mistakes, and we feel guilty about that. So yes, we're trying to also come up with a white paper on that, on the second victim. How can we support our healthcare workers, even more so our trainees, especially po yung mga ang nakikita namin sometimes that are may issues with safety are the newly hired staff, because they're graduated, they're board certified, but whenever you start work in an institution, yung onboarding process is really something that's very important, because you're less experienced. How do you get to where you're more comfortable providing care? So yes, ma'am, that's one. And for the SUCs, actually po we've had, as I said, the basic course housed in DOH. We're designing the advanced course that's for patient safety officers. And then what we're trying to do also is to revisit or update the curriculum, the medical curriculum, to include that explicitly. We've looked at the nursing curriculum, for example, in UP College of Nursing, and they have explicitly put patient safety and QI there. Interns are actually very envious po ako, kasi interns sila on their fourth year, they do quality improvement projects na. So they have a very solid program on quality improvement, and they're taking on QI projects in the hospital. But the medical curriculum, wala pa kami yan, and we're just introducing that. So we'd like to include that, and maybe have a conversation with the other SUCs on how to integrate that into the current curriculum. And as Sir Vic also told me a little earlier, is to actually have a patient safety competency list. How are what are the competencies for us, our healthcare providers, to be safe? And thanks, ma'am. I think Ma'am Agnes.
Yes.
Yeah, can I? Yeah. Well, we are faced with a daunting task. When this was presented in 2012, and it's taking us 12 years now, and I'm glad Vic is around, because Vic has been advising us. And I agree with him that we need to have a face, we need to communicate, we have to be organized. And I think we are slowly getting there. we're always starting with UPCM. For the curriculum, we have started, that was my promise to Dean Chong. And I think that was one reason why Diana was officially named as head. We are now getting into the medical curriculum. And we have, I think that is going to be laid out already this coming school year. Now, if we are happy with that, we will use APMC, which is the Association of Philippine Medical Schools, to incorporate this in the curriculum of other schools. This is what I did with HIV testing. I presented this to APMC, and all the other institutions agreed to take on this HIV testing among their medical schools. And we can do the same with the curriculum. Because nursing is way, way ahead of us when it comes to curriculum on patient safety. Second, right now we're doing trainings. We need to get into the good side of social media, and we have the conferences, but we are now applying for grants, so we have money to do this. I think that is one of our setbacks. We don't have a grant. I think we only have 500,000 from the previous patient safety. But I have already instructed Diane that we really need to apply for a grant because we cannot move without that. And of course, the last one is, I think we have identified 5 sentinel hospitals in our 41 schools. And since we cannot do this massively, we will use the sentinel hospitals to really be the model for patient safety. Because many institutions have a PS officer, but this PS officer are not exclusive for patient safety. They have other tasks. They were just named as PS. And we really don't know what the activities are. And every institution has its own program. So maybe a core curriculum that would be their seed to expand their patient safety. But to really get recognized and to really instruct, we plan to start with the sentinel hospitals. We are starting with PGH, but PGH is so huge. No? Ang daming pasikot-sikot sa PGH, ang daming problema sa PGH. And then the interaction is very different. Hopefully, we can work on the sentinel hospitals, Diane, and then get on to what Vic is suggesting that we should really be known. Dahan-dahan lang yun. But we need advertisements, we need more conferences, and we need grant money. So we will be applying to PCHRD and DOST for that. Yeah. And maybe CHED. Yeah. May pera naman sila.
And can I just add, ma'am, actually there's a call for proposal from CHED, you know, right now, and the deadline is this June, I think. So maybe, yes, Dr. Lachica, I just received one, so maybe you could submit a proposal. Yes, thank you very much for all the answers.
I think for CHED, lalo na kung tirahin mo yung curriculum.
Yes, po.
Kasi
Yes,
meron silang special,
yes, for the
meron silang funds for that.
Yeah. That's why I mentioned, because I think it's very important that we really educate also. SUCs should be involved, and we should really give them training, because it's not just UP, it's not just UP College of Medicine who should do this.
Yeah. Well,
And
CHED gave 200 million for clinical simulation, Joey. So why can't we not get that much money for patient safety?
Or more.
And if we are a good academic hub, we can really convince them to spread it out to the SUCs.
Okay, I think all the questions have been addressed either directly in the chat box or in this plenary. May we have a last words from our reactors and our speaker, and then Billy will close the session this morning.
Ask one question.
Wala na.
Wala na.
Last words na lang.
Dr. La Peña,
Yes.
would you allow me a
You have a question? Oh, of course.
If I can, just one before I start my closing.
Sorry. I'm sorry for assuming you didn't
So so now his patient safety implementation is elusive, and I was It's a 12-year enterprise already from a dean's standpoint. And Dr. Malabonga asks the question is, how do you know that you are making progress? So the question I have is, we have to start baseline. So I will ask a pointed question. About a few years ago, there was this timeout in surgery. Timeout. Tayo muna. Yan ba yung totoong site na ooperahan natin? Ano? Ito ba talagang meron bang informed consent diyan? Naligo ba yung pasyente natin? Nabigyan na ba ng antibiotics? So the question that I have is, do we have basic data? For example, from the Baguio General Hospital. I mentioned Baguio because they have such an interest in, sir, pwede ko kami mag-attend dyan sa webinar. So in this, I campaigned to all the DOH so that we have the data in DOH hospitals as to whether the prevalence of wrong side surgery is delineated. Baseline question. That, yeah. Is the data available now? Oh. No. Oh.
Ayan, wala, no?
Yes, I'm looking at. So there's no data on the actual frequency or parang percentage of it being done, but in our study, only less than half of the hospitals, more for DOH, less for LGU, actually look at timeouts. But when we asked them about their rates, they didn't have rates, sir, kasi it's all counts. So minsan wala pang yung percentage of let's say 100 surgeries, how many of the 100 times that the surgery happened was the timeout done 100 times? Walang ganon din, sir. So it's not really that the hospitals aren't measuring or they aren't counting, and they're not using that to promote safe care.
Yeah, that's one aspect of this program that I already mentioned to Dayan. We need to be a database center, Joey, diba?
Yeah.
Wala talagang database. And if we are kind and humane and not yung hindi tayo maninisi o magsusumbong, I think we can get them. No? Kasi nakita na namin yun sa 41 hospitals. But eventually, one of the projects that I wish this program would take into is really being a center for database. Yun, wala eh. Like, very relevant yung kay Billy, pero wala naman nagsasubmit, walang kumukuha. Kahit sa PGH, kulang-kulang din talaga. Surgery meron silang checklist. Medicine, I don't think we have that. So, kaya nga daunting eh. Kung wala ka nun, paano mo talaga i-measure ang patient safety? So, maraming trabaho.
Dr. Ray Pagtakhan has been waiting to ask a question. Dr. Pagtakhan, yeah, Ray?
Yeah, thank you. I am keen on knowing about when you discuss the patient engagement with families and in the context of reliable care and safety. I just want to know what specific endeavors or initiatives have been taken within this in that category, and are they being measured in terms of effectiveness? And is there an ongoing project, say in a healthcare facility or in the community at large, as an example?
Thank you, sir. For the measure, sir, what we found out in the study were there was really sparse. So yung level of patient engagement, as I said, was just in the form of asking for a satisfaction survey. But we have tried to, we've talked to DOH about this, and they've included patient engagement score in the patient safety indicators. It's the level at which patients and families feel that they have been engaged and considered and partnered with during the healthcare journey. But admittedly, sir, as far as patient engagement is concerned, if many of the hospitals that we visited, parang it's just more of telling them their rights. When they get admitted, what are your rights? That's their concept of what patient engagement is. So there's this need also to make hospitals aware that that's not patient engagement. True patient engagement means that you're actually taking their values, preferences, they're the center of it all, and they're making the decisions with us. And as far as initiatives are concerned, we have tried to educate about shared decision making, for example. We've also just in very quickly with our PAPO conversations, yung patient organizations, we'd like to also include actually patient and family count representation in the hospitals. So in the boards, in the QI boards, or in the management committee meetings, no, so that their voices are heard. So yung family council is something also that they're trying to lobby ever since. And I think it's good to note lang po that in the patient safety program, the technical working group, which I've been a part of since 2018, a patient is there. So hopefully the representation of patients as far as policy is concerned is there. But I do feel pa rin that we need more.
One quick supplemental.
Yes, sir.
How do you think an annual educational seminar engaging patients and their families on a given topic, in this instance on safety, etc., and perhaps in other instances about a certain disease management, so they will come to know what is good management, and if their doctors do differently, then they will be able to evaluate, because without that background, it may be difficult. How do you think, how do you see holding or encouraging holding annual educational seminar engaging patients and families, older patients and families, say in a healthcare facility, easier to do, or nearby, or in the community at large? Is that a possibility?
Yes, there's an excellent idea. I think awareness is really one. So an annual thing, an educational seminar or workshop is really helpful. In fact, when our conversations with Papo, they really want to know more about safety. And we did have a forum last year in lieu of the Congress where patient engagement was the topic. It was the entire convention. It was an online thing. I can share the recordings with you. Half of the speakers are actually patients. So we saw what their experiences are, what their needs are, ano yung mga complaints nila, and what they wanted us to do as healthcare providers. But apart from awareness, I think the key also is an explicit infrastructure where they're involved in policy making and in decision making. Because they can be aware, but if they don't have a voice there that's very explicit, nakakalimutan natin sila, no? The patients and the families.
See, every year, when I was still in practice, we were holding, as an experiment, I call it, an annual educational seminar. And I should reflect with you, it was well received. I thought it would only be for 1 year. And until I left, it was still ongoing every year. And the families and the older patients were very receptive and grateful for hearing actually from the healthcare providers that they are being treated, so-called, they're given first-hand information, not in the hospital, at the hospital bed, but really in a seminar. Thank you.
Thank you. Thank you. This is getting to be really exciting and interesting, but like all things good, it must come to an end. We would like to ask Diana, Dean Agnes, and Vic to give one last pabaon, ika nga, no? What do you want us to take home from this session? We apologize to those who still want to ask questions. You do have the contact details. Perhaps you can communicate with them directly, especially those who are interested in workshops or courses. But pabaon, please, from our speaker and reactors.
Pwede po ba yung reactor muna? I'll answer another question lang on the chat.
Request po na mauna yung reactor. Gusto niya maging huli.
Daya ka. Well, I think just keeping tune. We will be invading the social media, and hopefully we can spread the activities to you and join our seminars. They're all advertised. Thank you.
So when it comes to quality and patient safety, just wanted to let the audience know. I know there's a lot of stuff that Dr. Lachica brought out, but quality and patient safety, they're not an entity. They're not an office. It's actually an environment. And if we are to practice true quality and patient safety, that environment has to permeate all corners of your organization and your facility. And then we all have to breathe it and we have to live it.
Last words from me. I gave a very daunting picture nga, no, of safety, but and Ma'am Agnes has said when she recruited me, this is a lifelong task. But hopefully nga in our lifetimes, we can really get to a place where people are not just more aware, but they're committed to safety. And it's never just one person also who can take and get the job done. So I'm happy that everyone is here. They're on board. I think they're excited to go back to their institution. So I hope we can really foster that engagement and collaboration, and we're here to help. Thank you po.
Thank you. Before my co-host closes, and I turn it back to Billy, we would both like to request our president, Gladys, to say some closing words as well. We're hopefully not putting you on the spot. Wala po sa program ito. But
Yeah.
you have such a
Bale, magaling yan.
chat and so many participants. So I thought you should want to address us all. Yeah.
Thank you very much for putting me on the spot. So again, I would like to commend Dr. Lachica and the whole team for this very successful fireside chat on patient safety. And I would just like to introduce PAASE to the participants. We're a professional organization that is composed of scientists and engineers based not just here in the Philippines, but in other parts of the world. And we have all of these activities to reach out to our country to help in the dissemination of information about science and technology. So one of these activities is actually the giving webinars. So, and I would like to personally thank Doc Billy, who's been really very active and been inviting a lot of possible speakers. And then, so we're very grateful to UPMASA. We've been collaborating with them since last year. So UPMASA po is welcome. So if you want to sponsor a webinar, just let us know. And also we'd like to announce that we have this annual PAASE meeting and symposium. This year it will be a 10-day caravan. We'll be having we'll be doing in 4 universities. We're starting it at University of Rizal System for 2 days, followed by UP Los Baños, where I'm based, for 3 days. That's the main event. And this will be followed, we will go to Batangas State University, and then it will culminate at EVSU, Eastern Visayas State University. And the theme is really Filipinos, scientists across borders. We would like to showcase the Filipino innovations, okay, across all of these across all of these sites. So please, we have our website, paase.org. Feel free to look at it. And we are inviting you to be part of our annual symposium, meeting and symposium. We call it APAMS, and also all our activities. Too bad you missed Dr. Joey. We just had our Fireside chat also last Wednesday about GMOs and biosafety. We're coming up with a position paper and a public statement supporting the use of GMOs here in the Philippines. Again, maraming salamat po for this event. Congratulations.
Oh, Billy.
Is it my turn, Sir
Dr.
co-host?
Yes, sir.
The first thing that I would like to say is that, or the last thing is that it's really heartwarming that about 164 participants attended this seminar. I really tell you didn't expect such a large number. As you can see, when the dean proposed this topic be taken up, ano ba talagang nangyayari yan? But the presence of the attendants this evening from Batanes to Jolo and everywhere else really emphasizes that this is an important area that we are need to improve. Let me see. So a little bit of an advertisement. I tell you, this webinars are really insightful. I learn a lot. Just 2 days ago, out of a sudden, this conference on gene-modified organisms came up, and there were a lot of participants from the science community in the Philippines. So science is flowering in the Philippines. I would like to tell you that the leaders of science are here in Washington, headed by Undersecretary Leah Buendia. And I had the opportunity to escort them to the Walter Reed Army Institute of Research because of the interest in establishing the Vaccine and Virology Institute of the Philippines. And in fact, PAASE has taken the lead in trying to get that going. I learned from Dr. Jaime Montoya while we were conversing in the car that they had an audience with Senator Pia Cayetano, that I think the bill will finally pass and we get all these conversations going. So, Dean Mejia, Dr. Malabonga, Dr. Lachica, and least but not last, Dr. La Peña. Thanks. Good things will come to an end, but hopefully the next time we are actually going to be presenting the Philippine Genome Center, hopefully at the end of May, where that is an exciting area where we're trying to define how genes affect all of us and how we can use the technology to better our health. So, sir, good evening, everybody. Thank you for joining us, and I hope you will join us again. Dr. La Peña, stay healthy, sir. We need you. Okay. Good night, everyone. Thank you,
night.
President Completo. Thank you. Thank you.
Bye.
Thank you.
Thank you po.
Okay. Thank you, Dr. Lachica. Thank you, Vic.
Thank you. Thank you.
Yeah.
Galing, Diana.
Galing. Okay.